There. Is it shared now?
Yes, you're good.
Okay, sorry. So I thought it was shared since the beginning. So I'm going to skip. Okay, so this is the agenda for today. Study designs, how to choose what you read, how to start reading the article, and then how to critically appraise the article. And we'll go through these step by step. So let's dive in. So the first step is about study designs. And this is only a brief introduction. It's a brief overview about what types of studies that you could expect. Now, when you're trying to find a study, you're basically looking for the current best evidence. So current meaning the most up-to-date, the latest, and the best. So you're not looking for the worst evidence, obviously. And to look for current best evidence, you could either look for a primary source or a secondary source. A primary source is something like an original article, a survey, a case series, case report, a conference proceeding, or an abstract. This is usually searchable through a PubMed search engine. And then a secondary resource is something that is taken from primary resource. Someone has already read the primary resources and started making secondary resource, including a narrative review, which looks just like a textbook, for example, or a systematic review article, or a meta-analysis, or a book review. A very good example is UpToDate. We all use UpToDate, and it's kind of a mixture between narrative and systematic review. Now, primary sources is what we're going to talk about today. And for primary sources, otherwise known as clinical research, we divide them into either observational, where you do nothing, you just collect data on people, or experimental, where you actually do stuff to people. And you give them drugs, you do some diagnostic modality, you try some new machine or new ventilator, for example, in critical care. So experimental is basically what we call clinical trial, whether diagnostic or therapeutic. Clinical trials are probably the highest level of evidence, although these are more expensive to do, so you won't find much of them. But you will find more observational studies, and these can be further divided into either descriptive, where you just describe a case or a group of cases, or analytical, where you actually analyze this group of cases against another group of cases. So two groups where you analyze both of them. And then descriptive can further be subdivided into either a case report, a single case, which is a rare something that someone found and published, a cross-sectional study where they take data at a section in time, for example, a survey or a questionnaire, a case series, which is basically a group of case reports with similar characteristics, and you publish them as a case series instead of a single case report. So these are just description of data. And then there's the analytical part, the analytical observational studies, which involve, for example, case control. And basically case control is a case report, a case series, but then you have another group of controls to compare with your case series. So you describe the case series, which is descriptive, but then you have another group of controls so that you can compare characteristics. Or you could read a cohort study where they follow up a group of people and see their outcomes, whether prospectively or retrospectively. And then meta-analyses are considered analytical because they analyze studies. So this is only a brief, and you could read further to find out. Now, the second step is, what would you read? So how do you pick the article that you need to read today? It all depends, obviously, on what you're looking for. So, for example, if you're looking for an idea of research, that's different than if you're doing a topic review. If you're reading for an exam, you're reading for your residency, or you're just reviewing a case that you have seen at the bedside. So if you're looking for an idea for research, you would most likely require some original research articles, like primary sources, as we mentioned. An RCT or a cohort study, case control, depending on level of evidence. But if you are looking for a topic review, an update of your diagnosis of DKA, for example, then you'd more likely go to a secondary source, a narrative review, a systematic review, or meta-analysis, for example, UpToDate. Now, probably now we're like into the, that was all just an introduction. Now this is the main idea of the lecture. So how do you read an article? And the cardinal rule here is that you never start reading the article from start to finish. Obviously, that's time wasting. Plus, there's too much at stake when you're looking at multiple articles, for example. You're looking at the best evidence. So reading each article from start to finish is probably not time effective. So then how do you better use your time and effort to read an article? You go through simple steps. Step number one is reading the title. If it fits your needs, otherwise you throw that article into the garbage. Step number two is looking at the abstract and conclusion. And again, if the abstract conclusion works well for you, otherwise you throw it out. And then step three is reading the full article. So you only reach full article once you're happy with the title and then happy with abstract and conclusion. So let's start with reading the title. So is the title related or representative to your topic? Is it relevant, basically? The title is usually used for search in the search engines to find that article. So it has keywords. And these keywords, in order so that you know whether they are relevant to your own idea that you're looking for or not, should conform to the PICO question. I hope you've already been through the PICO question, so I'm not going to concentrate too much on it. But you already know that, you know, what P stands for: population, intervention, comparison, and outcome. So the title usually should have the PICO question. A well thought out title should have the PICO question, obviously. Some titles are very poorly thought out. I'll give you an example for a therapeutic study. For example, in a population of TIA, transient ischemic attacks, does an intervention of adding Plavix, clopidogrel, compared to aspirin alone, does it reduce the incidence of the outcome of stroke? That's a therapeutic question. A diagnostic question, for example, in a trauma population, polytrauma population, does the use of ultrasound compared to the use of CT scan in the abdomen, for example, does it detect bleeding as accurately? You can make these into a title by, you know, doing a simple English sentence. Is Plavix more effective than aspirin for prevention of stroke post-TIA? Simple. Or for the diagnostic study, is ultrasound as effective as CT or more effective than CT for detection of bleed in trauma? Usually it's like as bad, and for diagnostic, it would be like non-inferiority. Anyway, so this is a simple way of telling whether this title fits my needs or not. If it's a different population, if it's talking about ultrasound in ascites, for example, that's not trauma. That's a different population, then it doesn't fit my need, right? If it's comparing ultrasound to, for example, comparing ultrasound by a clinician to ultrasound by a radiologist, that does not fit my need. I need to know whether ultrasound is as accurate as CT, the gold standard. And obviously, if it's ascites rather than bleeding, then the outcome is totally different, right? Now, you determined that this title was fitting your need, looking at the PICO question, and you wanted to continue and read the abstract. The next step is looking at the abstract and conclusion. You need to know whether this abstract has clear objectives and hypotheses, and whether the conclusion is what you're looking for. So how do abstracts look like? Basically, they look like this. There's a lot of entangled wires in a full article, and then they made it very short, concise in an abstract. They made it short by requiring the article writer to limit their words. Basically, they asked them, some journals ask for 250 maximum words, some journals ask for up to 400 maximum words. So it's a very short, less than a page thing. And it looks more like this. with a title that you have already looked at, followed by the first step of the abstract is the background, followed by the methods. Background is like, we'll go through this when reading the full article. Followed by the methods of the study, what they found out, and what's their conclusion, their final conclusion. Reading the abstract should not take you more than a couple of minutes, but it gives you so much information, and more importantly, it gives you so much questions. So when reading the abstract, you could have more questions about the study because you think the study fits your needs, but you're thinking, okay, how did they randomize those patients again? Wait a minute, did they include pregnant patients or did they not include, did they exclude these? So a lot of details might not be mentioned in the abstract, but if you think the abstract fits your needs, then this abstract should generate questions where you actually would write them down or keep them in your brain, and then you would answer these when you read the full article. And that's step number 3. Your abstract and conclusion looks well, and you think this article fits your needs and you want to read the full article. Now it's a start to finish. Now it's the entangled wire. And basically, all articles are arranged in the same way. IMR&D, which is just like the abstract. After the title, which describes again what the research is about, the introduction part is basically the why. Why did he do that research? What's the context? What is known? What is the information that is already known about this topic? And why is there a knowledge gap that needs to be filled by this research? Basically, they would mention all the they would do literature search. They would mention all the previous research that was published about this topic. And then they would produce why this study was lacking, why nobody has already done this, and why they need to do it now. And that's the why. The next step, which is M for methods, and that's the how. So we established that he needs to do the study. This is why he needs to do the study. The next question is, how did he do the study? So what's the methods? Basically, is it a randomized controlled trial? Was it a case series? And exactly how did he do that? How did he randomize? How did he control? How did he control variables? How did he analyze? So all the stuff in the methods and all the details are usually in the methods. And then the section that we all like, and many of us like to jump to the results section, but I urge you not to, because you already know the results from the abstract. So now you're more concerned about the methods section. Anyway, so the results section is basically the what. We learned why he did this research, how he did this research, and then what did he found. We need to know what he found. Did he find any good results, and are these results actually significant? The results section is usually presented in tables and graphs and the like. And then the last piece is the discussion and conclusion. We know what the results were. We need to know so what. So were these results going to change our practice? Do we need more research, which is usually the thing. There is no study that will tell you that's it, we've figured out everything. Every study would tell you we probably need more research. Science is a bottomless bottle. And then the author should provide references. Now, if you look at these steps one by one, they actually copy the abstract, right? Or it's the other way around. The abstract actually copies the main article. And remember, when you're reading the IMR&D, the full article, you're trying to answer the questions that you have already gathered from the abstract. Now that you have read the article, you need to know, is this article actually worth applying or not? And that's the part of the critical appraisal. So appraisal is basically looking at the literature so that you can realize whether this is good evidence versus garbage. And in order to realize that, there are set steps. Some people might think it's intimidating to do the critical appraisal because the sheet is so long. But then if you just lump them into main subtitles, you'll notice that there are only 4 steps looking at any given article. The first step is whether this article has a focused question. The PICO, the title. This article fits my needs or it doesn't fit my needs. Some articles are totally unfocused. For example, someone would tell you, like, what is the best assessment of trauma patients? What do you mean the best assessment? That is totally vague. That's not a focused question. It's not a PICO. So if it doesn't have a focused question, you throw it out. This article is not worth reading. But if it does, the second most important question is validity, otherwise known as internal validity. Validity meaning, is the study designed well? Where the methods, that's where the methods section comes in. So validity is in the methods section. So if it was well designed, well analyzed, well randomized, well blinded, well controlled by gold standards, we'll go through these in a minute, inshallah. So why validity is the first one? Because if the methods were wrong, if the design was wrong, then the results will definitely be wrong. Even if the results look shiny, but if the methods were wrong, it means the results are wrong. Garbage in, garbage out. So the study has to be valid internally. The next step is, what were the results? The magnitude of the results. Does this study actually produce results? Zero difference? Some difference? Is this result significant statistically? And the magnitude is basically found in the results section. So the validity in the methods section, magnitude is in the results section. If it has results that you care about, otherwise you throw it out. And then the last step is applicability. Can you apply these results in your own patient population? Applicability is otherwise known as the external validity. So can you validate these results externally in your own patient population at the hospital? So basically, 3 questions plus the title. Title first, which is focused question, and then the 3 main questions: internal validity, results magnitude, and then external validity or applicability. 3 main questions. Like, if you go to this website, the Center for Evidence-Based Medicine in the UK, many websites with worksheets on how to do credit appraisal, but this particular website is something I love. I've learned on it in residency, and I continued using it now as a staff. And in the CEBM website, basically, for example, for therapeutic studies, they have ready-made worksheets, and they continuously update and upgrade these worksheets. These worksheets there, what question did the study ask, right there? And then they mentioned patient information comparison and outcome, the PICO, right? So is this a focused question, or is this a totally vague research question? The next, which is most important, as we said, is the internal validity. And for example, in a therapeutic study, the first question would be, was it randomized? Obviously, if it's a therapeutic study on a drug or a device, then it has to, the best would be a randomized study or a procedure, drug device or procedure. Anyway, so it has to be randomized, and that's we will get to the importance of randomization in a minute, inshallah. Were the groups similar at the start of the trial? Both groups, the intervention and the control group, they have to be similar, obviously. Yeah, and you cannot have a control group which is healthy and an groups treated equally, like patients who received Plavix and patients who did not receive Plavix, both of them should be the same in terms of, for example, anticoagulation, enoxaparin. Both of them should be the same in terms of aspirin. Both of them should be the same if, for example, they were subjected to mobilization, physiotherapy. You should treat both groups the same. Otherwise, one group would be better than the other in terms of outcome. And then were all the patients accounted for? And this is basically means dropouts. Do you have any dropouts? If you have randomized people into two groups, and then some people here dropped out, then you know that your randomization has been يعني ايش يقولوا اخترب يعني basically it's not functional anymore. يعني you ruined your own randomization. And then the outcome assessment, and we're still in the internal validity. The outcome assessment should be blinded. يعني the one who does the outcome assessment should not know whether this patient received Plavix or not, because this will affect their judgment, right? And this also includes the patient. The patient himself should be blinded. The treating physician should be blinded. The second question is about magnitude. We finished with internal validity. The second question is the results themselves. So what were the actual results? The result is that mortality was higher in this group versus this group. And the results are usually presented as either relative risk, absolute risk reduction, or odds ratio. We will go through these very quickly. And sometimes they are presented as number needed to treat. Again, we'll go through this very quickly after this sheet, inshallah. Once you know what the results are, you have to know how accurate these results are. These precise results, because you know this is only an estimation of the result. Again, I will explain to you what estimation means. The last question is external validity, which is, can you apply these results on your patients? And this basically goes with whether the patient population in the study is the same as the patient population in your own practice. Usually we go through inclusion-exclusion criteria, and then we will know that if, for example, if you're trying to look for people, for pregnant people, and then this study has excluded pregnant patients, then that study does not apply to your patient population. So the ones that we mentioned that we will explain are now here. So this is what we call the bell curve. The bell curve is the normal distribution curve. So for example, if you take a random sample of the population, let's say you measured IQ of your own population. Let's just say the full population, everybody, the 32 million people. And then you measured their IQs and then you plotted them in a graph. You'd usually find that most of your patients fall around the average, the mean IQ. Let's say around 100. And then 34% would be one standard deviation above, and another 34% one standard deviation below. The total is 68%. So 68% of your population would fall within one standard deviation, plus minus one standard deviation. The standard deviation is calculated from the actual study. And then if you take two standard deviations, that would be around 95%. So the idea here is that if you take a random sample of the population and then plot their IQs, it should also produce a bell curve, a normal distribution curve, because this is how God created Earth. God created people, and some people are outliers here and outliers here. That's how Allah created us. And we like two standard deviations because that gives us around 95% confidence. Now, if you take a sample which is not randomized and it will not represent the population, for example, you take a bunch of smart people and then you do their IQs, obviously their IQs would fall purely here. If you take a bunch of not so smart people, then their IQs fall mostly here. So that's not normal distribution, and it does not represent your population. And that's the importance of randomization. The second concept is about risk estimation. So when you're reading a result and you're trying to estimate the risk. For example, the game of darts, a very good example. You're a very good gamer and you know that you can nail the middle square, the middle circle. And then you throw this dart 6 times. Each time it would be around the circle or within the circle. It doesn't have to be in the circle every time. And that's called random variation, random effect variation. This is, again, another fact of life. If you try to come early to your work, for example, let's say your workday starts at 7, you will invariably arrive sometimes 7:01 and sometimes 6:59, right? You can never arrive at 7 o'clock every time. صح؟ لازم يكون في شوية random effect variation. And that's why risk is always estimated. It cannot be totally pinpointed. And with the risk estimation, around a specific risk estimation, you will need a confidence interval. So you estimate that your risk is, let's say, around here. But then you're not totally sure that your risk is here. It could be here, or it could be there. It could be above or below. It could be an outlier, right? And you're only sure that your risk falls between these 2 lines. And these 2 lines, we have an agreement, everybody has an agreement, all scientists, that we use the 95% confidence interval, which represents 2 standard deviations above, 2 standard deviations below. And that's how sure you are. You're sure, you're 95% confident that your result falls within this range. And the more accurate your study, the narrower your confidence interval. Study accuracy is usually gained having more people. The bigger your sample size, the more representative of the population, the more accurate the result, and the more narrow your confidence interval. I hope that makes sense. Another concept is the number needed to treat. And I won't dwell so much on the calculation. This is the 2x2 table for therapeutic study, where we have control event rate and experimental event rate. Basically what that means, for example, in our Plavix study, the event is a stroke. That's the outcome. So what's the rate of stroke in the control group? That's this one. What's the rate of stroke in the experimental group? The Plavix group, right? And that's basically how you compare. So if you go stroke in the control, that would be the stroke reduction, the absolute risk of stroke reduction. That's the absolute risk reduction of stroke, ARR. I hope that makes sense. So for example, if 3 people have stroke here, 3 people had stroke here after patient, and 4 people had stroke here. So it's going to be 4 minus 1 minus 3. That would be an absolute risk reduction of 1 stroke patient. Sometimes we use relative risk, which is the absolute risk divided by the baseline, the control. So if this is 1, we've already established from here, this is 1 stroke less patient. Or 25% absolute risk reduction of stroke. And then you have the number. So each 1 patient you treat will have a reduction, will not have a stroke. Usually you won't have a number calculation. But for example, if you have an absolute risk reduction of 25, 1 divided by 0.25, so that would be 4. So 4 patients have to be treated so that 1 of them will you will save him the stroke. And that's the meaning of number needed to treat. How many patients you need to treat so that you can save 1 patient. So that's, now you see that number needed to treat makes more sense to the simple mind than the absolute risk reduction or the relative risk reduction. Like the second type of studies, I hope I'm not will have a PE, for example. Let's say it's 30% likely. And then you do the test with a likelihood ratio of 10, a positive likelihood ratio of 10. So then you multiply 30 by 10, it's actually going to be more like